Discussion, and with this we move on to our next talk by Dr. Shan, who's come all the way from San Francisco. Dr. Lin is on the Board of Governing Council of the WGP, and he'll be talking to us about MIGS and giving an update about it.
Thanks to the organizers for inviting me and putting this together. I'm really excited to talk to you about new and upcoming MIGS. It's going to be a whirlwind because, of course, there's lots of MIGS out there, and I'm actually only covering some. So if I go over a few minutes, please bear with me. We're gonna cover a whole range of different MIGS, trabecular and canal procedures, suprachoroidal shunts, which are making a comeback, and finally, a new term coined by Ike Ahmed's, minimally invasive bleb surgery. So not quite a trabeculectomy, but trying to get some of the efficacy of a trabeculectomy. So let's start with trabecular and canal procedures, which is the true MIGS, so to speak. And these are some of the ones that are existing. And let me say that, first of all, I come from a very United States-centric view, so these are going to be a different set. But I think the newer ones will be of interest to all of you and perhaps available in Asia in the future. So iStent, of course, and Hydrus are available in the US. Many ways of going into the canal, expanding it with Omni or iTrack, or removing the trabecular meshwork, doing a goniotomy with like the Cahook Duo blade. So what are some of the newer ones? The newest one on the block is C-Rex. It's already available in the United States. Same idea, you're trying to actually remove 360 degrees of trabecular meshwork, and you have a guide here as well. And is there an advantage to this? We'll take a look, and there may be some added advantage of actually removing almost the entire Schlemm's canal. So it's a goniotomy. It's a trabecular excision as well. It's already just recently, a couple months ago, become available in the United States to do. And they have ongoing clinical trials. Their existing clinical trial results look very positive. And you can see that it's almost like a very thin guide wire, but there's also a little bit of a handle on the edge that's removing the trabecular meshwork. Let me see if this video will play, and you can kind of see what happens with this procedure. So it's very similar to what you would do with many of these GATT type of procedures where you remove or you enter Schlemm's canal. And it's guided by this blunt-ended cannula. And as you go around, it also has this little fork that's removing trabecular meshwork as you go around. And there's also some scientific evidence or animal evidence and in vitro evidence that you're actually removing the outer wall of Schlemm's canal, which may help outer flows such as through collector channels as well. And now we're going to go to suprachoroidal shunts. This has been an area where people have suggested and done, these suprachoroidal space and accessing that for over 100 years. And so how come we don't have an existing suprachoroidal shunt? Well, there have been previous ones tried. And as you see here, these are probably all familiar to you. The Gold shunt, the Starflow, the Aqua shunt, CyPass, which was available for a few years in the United States. But they all had their complications and side effects associated with them, which created some problems. But this is a very rich potential space to use almost an internal bleb so that you don't have the risk of infection as a way to lower the intraocular pressure. So these are just 3 of the devices that are either available or in clinical trials in the US. AlloFlow is already available. We'll talk about that. This sclera-based. We're going to talk about the MiniJect and a little disclosure on the medical monitor for the MiniJect device in the US. Intersil, which actually is very fascinating, that you don't even go through the anterior chamber angle. So we'll talk about each one in consequence. The AlloFlow, ingenious. It's using scleral allografts, so it's using eye bank eyes, and mostly you throw away the sclera after you take the cornea for corneal transplant. So you're taking that tissue, and they've already formed it and put it into the device so that you inject this to create a suprachoroidal space and outflow. It's non-biodegradable, and it's your own sort of homologous biotissue here. And you can see the device here. It's white sclera, and it's to create a suprachoroidal space in order to have enhanced uveal scleral outflow. The ideal situation is what you see there at the bottom right, which is you have 2 of them in there, so that it's not just creating one space, but you're having a gap of space in between. As you scar down, you hopefully will still have that gap and the cyclodialysis cleft, so that fluid is still going through there. And this is allowing you, this is an ab interno approach. This is the histology you're seeing of that cyclodialysis. You're getting a larger outflow capacity than the trabecular outflow. So you know that with these trabecular stents and the goniotomies, we get to the mid-teens, right? Because you have the limitations of the resistance at the collector channels as well as the episcleral venous outflow. So you almost never get a pressure of 9 or 10 without medications with those devices, but you have that potential with these suprachoroidal. And what sort of draws the fluid in there is this negative oncotic gradient that drives that fluid into the suprachoroidal space. Here's the device itself, and you can see that in the actual human situation, putting two of them and having that gap, because there's going to be some scarring down. Some of the failure that we saw with previous devices like CyPass and the previous devices, over time, like a bleb, it's going to scar down, and then you're going to have a rise in pressure, which can be rather rapid when you have a closure of cyclodialysis. Here, you're keeping this gap, so you're creating this cyclodialysis cap and keeping it open with two of them if you use two of them. Although some people do use one because of the concern for hypotony. See if these videos will play. I don't know if we have a little time, but you'll see that there's a stepwise approach to this. When you go into the angle, you actually go with the cyclodialysis spatula, a special one that you actually create a little cyclodialysis cleft, and then you're also injecting viscoelastic in there. So you're setting everything up so that it's easier to put that scleral patch in. And let me show you what that part looks like on this video. And finally, here's, as we're looking at the video for the actual insertion of these stents, the anterior segment OCT, ideally you'd be just a little bit ahead of the scleral spurs so that you're not going to be wrapped around with PAS and the whole device ended up getting covered. And yet you don't want to be too anterior. Of course, the concern is corneal endothelial cell loss. And this is what it looks like afterwards. And again, that cyclodialysis in between this being kept open is really, I think, the ideal situation. A little bit higher risk for hypotony in this situation, of course. And you have the two scleral allografts next door. So what are the actual data on this? So of course, this is the clinical trial from the company with 1-year results. And you see the pressure went down from average of 20 to about 14 with good IOP control in about 80% of patients. If you use 20% as a cutoff, 84% success rate with over half of the patients, or 50% reduction in IOP medications. I'll next talk about the MIGS device, which is made up of silicone. In a way, similar idea. You're actually inserting this ab interno into the suprachoroidal space, and what's allowing the flow? Here you have these micropores within the device so that once you have ultimate scarring around the device, you still have flow through these micropores. And you're making a very small corneal incision as well, so it can be done by itself. It doesn't have to do with cataract surgery. But here are the steps of it. You're actually looking, gonioscopically, going in there. You can also make your own cyclodialysis clefts and even inject some viscoelastic if you like. And then your probe will go in there and actually inject it. You see the green band, and that's what you know that's going to be at the scleral spur, and then you release and you have immediate flow. And this is the post-operative view afterwards where you see the green band. It lets you identify where you want to be in terms of perfect placement. And this material is anti-fibrotic. Silicone is, of course, biocompatible. And it's really the technology is these micropores. So most of the device is actually space, empty space, 2/3 of it, so that fluid can flow in there. And even with integration of the cells around there, you're having absorption of fluid through the device. And here's the histology looking at that and all the micropores within there and the biointegration. In fact, you want biointegration so that it stays in place and you have a flow through the pores rather than a side cyclodialysis cleft. What are the results? These are the European results. It's again in clinical trials in the US. The European results show a reduction of 40% IOP from 24 to about 14, and high success rates in IOP reduction, target achievement, as well as a large proportion who are medication free. It's even gone out to 5 years. So if you're wondering, well, I've heard about so many glaucoma surgeries, they seem to work good for a year and then that's it. Well, these are 5-year data. Pressure does go up over time, as you would expect with any surgery, including a trabeculectomy. But even at 5 years, you have a high achievement of pressure reduction, 20% or 18 or below, and a good percentage that are medication free. And again, there's always complications with any of these devices. They're actually all probably overlap. There's risk for inflammation, IOP elevation, whether it be acutely or later on. Reduced vision, these again are single digits usually, and visual field defects, which may be the glaucoma as well, progressing. Rate of hypotony in this was 2.4% and a manageable endothelial cell loss rate. This other one I think is also very fascinating. They actually do it, again, I'll go over a couple minutes if it's okay. The suprachoroidal implant is actually placed through the sclera, and it's in the suprachoroidal space, and you don't actually go in through the angle at all, but they're showing very good results. Again, it's probably that negative oncotic pressure that is driving fluid into that newly created suprachoroidal space. And here's their results, even out to 3 years, a smaller number at that time, but a 33% reduction even at 3 years with this Ciliatec device. And medication use also goes down substantially up to 3 years. Large percentage are actually medication-free at 3 years as well. So we're going to end with talking about MIGS, minimally invasive bleb surgery. So there's a couple of new ones out there in the US. You're familiar, of course, with Zen and PreserFlow, and of course, PreserFlow is available here in Asia. And the new ones that I'm going to be talking about are MIMS and Aqualumin. One of them is available already, and the MIMS needs FDA approval, and Aqualumin is already available just recently. And both of them are basically penetrating procedures. But the idea is, can we get a safer trabeculectomy type of surgery? So we'll punch a hole through the eye, but it's a more controlled punch with hopefully less risk of infection and hypotony, for example. With the MIMS device, this is actually a machine, and you have to have something electronically that's going to drive sort of that needle through the eye, ab internally, to have outflow through the eye. And here's just the schematic showing that you go ab internal to the nasal angle, to the opposite angle, and then you place it with some confidence in that area so that it won't slip. And then very quickly you make a rapid penetration, and you will actually draw out some sclera with that, and then you have immediate flow, outflow. It's like a ab interno trabeculectomy. Let's see if this video works here. You inject mitomycin C often in these cases to help prevent scarring of the bleb that you'll create, viscoelastic filling, and then you'll see that it can be very rapid. You have to be in the right place, step on the button, and then you have penetration, and you'll see that you actually kick out a piece of sclera, but you have immediate filtration in this eye. Again, what are the results? It's nice to see these things. Its effect, as you can see there, with IOP and number of medications both go down either with standalone or combined with cataract surgery. So it's not quite the effects of a trabeculectomy, but the safety profile is quite a bit better than a trabeculectomy with a good reduction in meds and medications. I'll end with talking about the Aqualumin, which doesn't require a machine. It's rather ingenious, and I am a consultant for the company. It's ab externo, and so you're going underneath the conjunctiva, going through the sclera into the anterior chamber, and then withdrawing some tissue. So the idea of it is that it's actually back cutting. It's like a fish hook. And so as you pull back, you will cut a round cylinder of scleral tissue. And it's a rapid withdrawal. It's not hard to learn, but that's the benefit of it is that you need to suddenly pull out to take a tunnel of sclera with you. Mitomycin C, it is bleb forming, and because it's a small tunnel, it's a low risk for infection and side effects. So we'll end with the video on this device. And mitomycin C can be done before or after the procedure. I tend to do it after procedures, but before is okay too, because usually when you do it, it gets trapped within the conjunctiva. So rabbit studies have shown that it really doesn't leak into the eye necessarily by doing it before the procedure. And again, you kind of almost like tunneling a little bit for your tubes, but when you're withdrawing, you're actually taking a tunnel of tissue with you. And again, immediate filtration afterwards, and you want to see bleb formation right afterwards. So the results are, again, a small case series where the average pressure was 27 and went down to the mid to high teens on 0 meds out to 10 months. No serious side effects with this. So in summary, we've got all these exciting new devices, and these are just the ones in the U.S. Michael Coote has his own device, which I heard about. You know, I think it's the VW51, if I remember, and that looks very exciting in terms of its results too. Thank you very much, everybody.
Thank you, Dr. Lin. If you had to choose two top devices out of these, which would be your chosen ones?
Well, it depends on the patient, right, and their what their needs are. So if you have somebody who's just early glaucoma or ocular hypertensive, and you want a very low risk device, and you're doing cataract surgery, it'll probably be a trabecular procedure or a canal procedure. Very commonly, I'll do a hydrus, for example, in the U.S., or my other go-to is to do a canaloplasty. I'm a little averse to doing a removal of trabecular meshwork because I just don't like hyphema, especially with my combined cataract cases. They want to see better, and nothing like seeing that patient the day after with a disappointed face because all of their friends have good vision after cataract surgery and yours has a hyphema. So that's my avoidance of that part. And in terms of if they have more advanced glaucoma, I've already done, in part of the case series, I've already done the device that I showed it at the end there, where you actually have a needle that withdraws tissue, the aqualumin, and so that's available, and I'll probably start doing that as a device that I can do for more advanced surgeries, advanced glaucoma.
Sure, thank you.
I think very, very nice concepts, I think, Dr. Shan. When you talk about equatorial, I think I'm reminded of a procedure which was, I think, earlier done by some people. You are using the plasma fiber. So you have like a plasma energy. So you put it on the conjunctiva under the sclera and go into the anterior chamber, or even the posterior chamber, actually in the posterior chamber also. So you create that tunnel. So you're basically removing the scleral tissue and create a channel.
Yeah.
But somehow it hasn't actually succeeded over a period of time. Did you use that? Yeah. So how was it?
Dr. Ajit Singh had described this technique where he used to drain the posterior chamber. So his idea was that the anterior chamber should never get shallow. So he used to put 2 or 3 of those, with that plasma blade, he used to make 2 or 3 holes a little posterior to the normal limbus.
Like tunnels.
Yes, tunnels he used to make, and then they were just one-time kind of procedures. I don't know the long-term success rate.
But they will close with time, isn't it?
I mean, it didn't last very long.
Yeah, but I've seen some of them, they kind of close with time.
Yes,